to the Medicaid reimbursement systems that you will have to abide by under your payment regimen under Obamacare, by the way. As Paul Romer puts it, the number of different software programs that can be put on 1 gigabyte hard disk is 27 million times greater than the number of atoms in the universe. If you were to combine any 4 of the 100 chemical elements in different alloys and compounds in different proportions ranging from 1 to 10, you would have 330 billion possible chemical compounds. Now, those kinds of permutations are almost available to the human body, as Twyla pointed out. And yet we're talking about 3 types of treatments for prostate cancer, or 2 types of treatments for approaches to treating someone who's pregnant. That's so yesterday. Now, we are so far ahead of the curve, so far beyond that, but yet we are spending $1 billion reviewing what we've done in healthcare 30 years ago. It's like we're giving $1 billion to bureaucrats and economists like me, didn't even wear a tie today, to review all the books in the library, to tell librarians around the country what books they should buy based upon what was in the Library of Congress 30 years ago. Not even looking at what's going to be published, including my wonderful book, but what's already been published. So they're doing literature reviews. That's what we're paying people to do. I mean, we're going to take those literature reviews and say, well, we need more evidence to really determine what's the best use, what's the best treatment. And until then, we really shouldn't pay for anything new. See, that's how the game is played. Now let me give you some examples of how that is being played out today. And there's one example in my book, and I hate to be shameless about it. My daughter had an eating disorder, and she was in the hospital for 30 days, and she was discharged. And then she got sick again, and then she was brought back into the hospital. And once her physical signs were stabilized, she was kicked out again. And I went to the insurance company, I said, what the hell is going on here? He says, well, there's a federal study that said after 30 days, there's no evidence that treatment is effective. It was a study published by the Agency for Healthcare Research and Quality. Now, it turns out that her physician, her psychiatrist, one of the leaders in the field of treatment, said that, for another 10 days inpatient, we could really make a difference. She was really making progress. And I paid out of pocket to make a difference. And I did something after she was treated that I didn't want to do, but I formed a class action suit to say that relying upon the government to say, well, there's no evidence and we don't know, that's not a basis for payment. And we won. And I hate suing, and I hate using trial attorneys, but in this case I did. But I think, as an aside, I think that increasingly this is the way the government's going to use comparative effectiveness. So if you want to do something innovative in your Medicaid system, if you want to pay for something, they're going to say, well, it's not within our measure of quality, and by the way, it's not within our methodological way of defining quality. Now, I happen to think, as an aside, that that's a violation of the Due Process Clause of the Constitution and a violation of due process under the way that entitlements are delivered. And I think there's precedent. We can talk about that another time, that you as states will be able to sue HHS for not allowing you the flexibility to innovate. So that's one point. The other point is that the attack on innovation, the delay of, for example, HHS waited a year to approve Provenge, a drug, the first vaccine for prostate cancer. It is restricting the use of diabetes strips to 6 diabetes strips for insulin-responsive patients and 1 strip for non-insulin responding patients. It is delayed access for genetic tests for determining high responders for certain cancer drugs. I mean, I could go on. Comparative effectiveness is already being used to delay innovation, which is counterproductive. Why? At the CMPI, we've conducted studies to show that states that have the highest access to new medications have spend less on disability and less on nursing homes. That overall, the access to newer medications are responsible for keeping older people more productive. That people that have access to newer medications, based upon their individual response to treatments, the first time, save more money. Innovation, if you will, is the green technology of our healthcare system. So that comparative effectiveness is really an outdated approach to controlling healthcare costs. What you need and what's happening around the country, and I think the Center for Health Transformation is doing this, is developing real-time information on what works at the individual level, moving from AM/FM approaches to healthcare to iPod approaches to healthcare, if you will. So that, for instance, there's a company that we're working with called Remedy MD, which allows you to capture information on patients with rare diseases or cystic fibrosis, and you can see what happens when they come into the system at point A, follow them over a year and see, controlling for over 200 variables, what types of treatments or what particular treatments make the most difference in that patient's lives. Sometimes it's a drug, but in the case, for example, of infants with respiratory problems in the neonatal ICU, it's just tickling their feet. Just tickling their feet. Individuals in the stroke that have had strokes, we found that starting to feed people real solid food not only gave them better nutrition, but helped improve their total function. Combining different medications early on made differences. The fact is that the digital revolution allows us to individualize care earlier than ever before. So it's not, Obama was famous for saying, well, some people, if we find out that the red pill is cheaper than the blue pill, we should give everybody the red pill. No, we need to find out who does better on the red pill and who does better on the blue pill. Because as we all know, we all have the time and money to do it right the second time. What we need to do to save money on our healthcare system is use the information to do it right the first time. So it's not comparative effectiveness, it's individual effectiveness. And the way to do that is to give people the tools to be partners in their own healthcare. And there are things you can do at the legislative level to make that happen. There's lots of tools out there, and as Michael said, there's a lot of private sector tools that can bring about that individual revolution. It can't come from the top down. It has to come from the bottom up. Online tools there are rural areas in India where people are using their smartphones to monitor their blood pressure, to share information about taking medications. If they can do it in rural India, we can do it in the United States of America. And I look forward to, I'm excited and honored to have been participating at this conference. I'm glad that I met a fellow iPad user, and thank you very much for taking the time to listen to me.